So good morning everyone. A warm welcome to this FPP session. I am honored to see many esteemed faculty members from different colleges. This FPP aims to enhance our teaching, learning ability and share the knowledge. I hope in the next 3 hours we will be having enough research ideas, knowledges that will in future help us to grow ourselves. Now today we are having one of the esteemed professor in our locality area in West Bengal, Dr. Sudipto Saha. He is an associate professor in the Department of Biological Sciences at Bose Institute, Kolkata. He did his PhD in Bioinformatics Center, CSIR, INTEC, Chandigarh from 2002 to 2006 and worked as postdoctoral fellow, postdoctoral researcher for 5 years at Indiana University from 2007 to 2008 and Case Western Reserve University from 2008 to 2012, USA. He received DBT Ramalingaswamy Re-Entry Fellow from 2012 to 2017 and a member of European Respiratory Society. He has over 80 publications, conference papers and book chapters. His lab uses bioinformatics, proteomics and systems biology to understand lung diseases like asthma, MDR, TB and pulmonary fibrosis. He has authored a book, Pulmonomics, Omics Approaches for Understanding Pulmonary Diseases. Now, I want to call upon stage our principal sir, Professor Dr. Jubashish Sarkar, our coordinator and co-coordinator madam, Professor Dr. Mousumi Adho and Professor Dr. Uttara Basu madam and Professor Mousumi madam, Monisha Ghosh madam. Please. Now today's topic of this session is development in treatment of diseases using AI. Also, I would like to call Professor
Thank you for the nice introduction and thank you Dr. Sarkar for inviting me. Can you hear me?
Yes, sir.
So today I will be talking about developments in the treatment of disease using AI. So today I will be talking in two parts. First, I will be giving an introduction to AI and the machine learning. And the question is very simple: just can a biology researcher use AI? Or you can frame it in a different way: the person who is not trained in AI, can he or she can do it or not? So that is the first questions which will be addressed in my talk. And the second question is the development in the treatment of disease using AI. So can AI predict diseases, or can we automate the diagnosis process using AI based on symptoms as done by the physicians? Because if you go to the doctor, you talk about symptoms and doctor give you drug. The same thing whether you can do it using AI or not. part, which is very basic part, and I'll start that every industry wants AI, as you know. And the question is that can a biology researchers use AI or not? So if you look at this particular pie chart, you will see that every branch of science or industry use AI, whereas life science is a part of it. And the question is that why should biologists like me, myself, I was trained in a microbiology, BSc and MSc in microbiology and did my PhD in bioinformatics, and believe me, when I was doing my PhD in 2003, I was using AI. So one of my paper was published in Recurrent Neural Network, and that paper was published in 2006 in a journal called Proteomics and Bioinformatics. And believe me, that particular paper has been cited approximately 1,800 times. So AI is not new. What I mean to say is that, but the way people are using it now, why AI is becoming new? Because a huge amount of data is generated now. So that time in 2006 and 2006, AI was there, but the data was not there. The volume of data was not there. But now, why AI is booming up? Because the huge amount of data is there. I can use the AI to churn the data and come up with meaningful, important questions which you can address. So, I'm just talking about biologist point of view, but as I understood in the morning when I was talking to Dr. Sorka, that there are other people from different backgrounds. So, the big thing is that there is a data, there is a huge amount of data in terms of biological sciences, there is a huge amount of data, and all the researchers, they want a bigger picture. So they don't want to see something like a small question. They want to see what's happening with a huge amount of data. For example, in case of biology, you see there are many omics approaches here, genomics, proteomics, and images data like radio imaging data like CT scans. And there are a huge amount of data, and if you can understand, some are audio data, some are video data, some are photos, some are documents. So there's an unstructured thing are there. So when you have an unstructured things where you have a different types of images or photos or videos or documents or graphs, so can you integrate them? And can AI can use it? That is a big question in biology. So this was something which you need to understand. So when we talk about AI, so what does it mean basically? So AI means something which is basically a bigger subset where the machine learning and deep learning are the subsets. So we have to understand this part. And now the question comes is that what is AI which is not machine learning? What is AI which is not deep learning? So it's not that all machine learning and deep learning are AI. So ML, which stands for machine learning, and DL, which stands for deep learning, are the part of AI. So in case of biology, we know about the ChatGPT. So that the important point using the ChatGPT is that if you can read this particular sentence is that can we generate 100 important questions. So AI is used to ask the questions rather than giving a solution to it. So questions are more important. If you have a very good questions, then you can solve it. So AI is used to generate the questions, and similarly, along with ChatGPT, there is another came up very recently, which is called BioGPT. So BioGPT is used to answer the biological questions, and similarly at the back end that ChatGPT works, but it's very specific to biological questions. So coming on to the machine learning. So it's a very basic thing, but still I feel that I need to start with machine learning, because machine learning means computer learn from the data effectively without being programmed. Because many times people who want to do AI or ML, they want to use it, but they are not very good, or they are not skilled to do programming. The question is that can they do AI or can they use ML? In machine learning, the algorithms are trained to build a model based on the sample data. So you need the data. As I say, that why AI is very important nowadays, or why? Because huge amount of data is there. Because you need to feed the data to the machine learning to build up a model, and based on this model, you can answer particular question which you have in your hand. So there are the traditional approaches, there are KNN, NAR-based supported conditions that are generally used. So in this KNN, which is a very simple, straightforward way to developing a model, suppose is used by classified by majority of both its neighbor. Suppose in this figure you can see there are two type of figures. One is a triangle which is red color, and a square which is a square root which is there is another examples. So there are two set of examples. One is a triangular red and one is a square root. So the question is that if you are given with a green color unknown part, so can we say whether it's a blue or red? The question is taken. So when you talk about KNN, it comes with a number, for example, whether it's a 3 or 5. When you use KNN, you use a number KNN 3 or KNN 5. So suppose if you use KNN is equal to 3, what does it mean? It means it takes into consideration the 3 nearest neighbors. So for example, if I ask that what the unknown part being whether it's a blue or whether it's a red. So if you consider K is equal to 3, it means it's considered the nearest neighbors using the three examples, and based on that it will say that it is red. Quite understood. But similarly, if you can ask similar question, if you use K is equal to 5, then what will happen? So the answer is very simple. So if you use K is equal to 5, the answer will be different. Answer will be blue. Okay. So the nearest neighbors what you use consider whether predict, it all depends upon how much K value you are taking into consideration. So NICE base is very widely used for biologists. They want to understand the data basically, and they use a probabilistic model and use the Bayes theorem, and it's very simple. It's provided here. And believe me, when I took my postdoc and during my PhD, I used machine learning, SVM, all these things, and I went to do postdoc. My supervisor was more interested in NICE base. Why? Because NICE base allows you to understand the data. So they are not interested in the black box, because SVM and all those things are all black box. Basically, you don't understand how it works. But NICE base allows you to understand that which particular frequency is playing an important role and allows you to take the decisions. Okay, the features which are very important will come to you. So the next additional approach of machine learning is SVM, and suppose there are a few examples which are given in a solid dots, and there are some dots which are present here in the white color. So suppose you want to separate these closed dots and the white color dots, which are open one, and you want to separate those two things. So it's a classification based problem. So what the support vector machine does, it draws a line. So if you can draw a line in a number of ways. So you have to draw in such a way that the distance between the so the distance between the closed circles, which is a, suppose for example, if you consider it as a positive example and you consider this as a negative example, so you have to draw a line in such a way that the minimum distance from the positive examples and negative examples. So in this case, the support vector line is this one. Because why? Because it's a closest neighbor and it's a closest one. So in this way, you can draw a line. It can be imaginary lines, and that lines will allow you to separate between the positive examples and negative examples. So the question is that what is the difference between machine learning and artificial intelligence? So I talked about machine learning. So what is the difference? So AI solves the tasks that require human intelligence, while ML is a subset of artificial intelligence that solves specific tasks by learning from the data. I hope that you understood that you need to feed the data into some machine learning. That means that all machine learning is AI, but not all AI is machine learning. Okay. And how AI is linked to machine learning? Machine learning is applicable to AI. It is a process of using the mathematical models of data to help a computer to learn without direct instruction. Because you don't have to program, you don't have to do anything, you have to feed your data, and you develop a model based on the algorithms, and you come up with a model, and that will allow you to answer the model that allows you to predict. So if you look at this particular figure, and it says that artificial intelligence is a big set, and there are few things which are natural language processing, which are suppose knowledge-based graphs, which are part of the AI, which are not in the part of machine learning or neural network or deep learning. So what does it mean? Suppose there are some knowledge-based graphs which are part of the AI, but they are not machine learning. See, when you talk about machine learning, it means it has to be trained with the data. And similarly, there are some neural networks and deep learning. And deep learning needs that's a convolutional neural network. There is an RNN, which stands for recurrent neural network. So those are part of the deep neural network. And then in this way, you can frame it as an AI, ML, neural network, as well as deep learning. So many times in teach, people ask me that what are the examples of AI that are not machine learning? Because we know machine learning is AI, deep learning is AI, but the question comes that what are the examples of AI that are not machine learning? So, as I said, that symbolic logics, which we generally used, and the knowledge-based graphs, generally the gene ontology and all those things, they use knowledge-based graphs. They are all AI basically, but they are not machine learning. Why? Because they don't need any data to be filled here. The logic is here. It's a part of AI only, but they are not machine learning. So now comes to the deep learning. So deep learning, as you all know, that we say it's a neural network. You need some inputs and you need some layers. So in this case, there are three layers. There's the first layer, second layer, third layer, and within each layer there are the nodes. So suppose in the first layer there are 1, 2, 3, 4, 5, 6, 6 nodes, 1, 2, 3, 4, 5, 6, 7 nodes, but in the third layer there are 3 nodes, the fourth layer, and then you get output. So there are three basic things here. One is the input, one is the layer. The layer, there are some nodes, and there is the output. So there are two ways. There is a feed-forward neural network and there is a recurrent neural network. In case of recurrent neural network, what you need is you need another state unit which is present here, which is not shown here. The output will come to the state unit one more time, and then again you will further input. And every edges you see there is a weight assigned to it. And if you sum up all those things, then you come up with the weights, and that will be assigned to output. So, in the last year, which is 2024, 2 Nobel Prizes went to AI, and many people are happy, and many people were not happy as well. So, because you see that the 2024 Nobel Prize physics went to John Hopfield and Geoffrey Hinton, and again in the chemistry it went to James and John Harper, who is a very famous guy, and because he developed the AlphaFold 2, which is used to predict the structures, protein structures. So, believe me, there are paper came in last year, 2024, and they say that AI comes with 2 Nobels, and double wins speaks debate about scientific field. So, the scientific field say that there is no much understanding in AI, but why people gave Nobel Prize to AI. So, what you have to understand is that when Nobel laureates thought that AI is important, then we have to believe that yes, there is something in AI. We need to follow it up. So the applications of AI in biology. So that I forgot that there are many other people from different backgrounds, but since I am a biologist, I just put it as a in application in biology. So generally in biology we do protein structure predictions, image analysis, drug discovery, and the omics data. So I just take one by one. So as I said, that in case of if you do the protein data bank, there are many sequences are there, structures are there, but not all sequences have structures. So suppose there are proteins in human, if you consider human only, there are approximately 5,000 proteins. So maybe there are 5,000 sequences are known, but not all structures are not known. So if you consider with other organisms where the all sequences are known but structures are not known, so how to predict the structures? So the AlphaFold came into picture, and the first paper was published. This is AlphaFold first version, which was published in Nature in 2021, and the Nobel Prize got in 2024. It was due to AlphaFold 2 basically. So what they need, if you give all the sequences to them, they train basically, they know what are the folds, what are the domains of the protein sequences, and they come up with the structure prediction. So the input can be the DNA sequences, the input can be the amino acid sequences. So if you give the DNA sequences or the amino acid sequences, it can predict the structures. So now comes that how.
Sir, can you please basically how the alpha forms will be the better prediction of the protein structures. Can you give some better idea?
So what does it does? Suppose every protein has some domains and motifs are there. So they train the domains and motifs. So domains are the part of the protein which are used to function basically. So suppose there are folds, motifs are there. So they learn the domains and motifs and folds what will be global structures and they learn it. So if you give the unknown sequences, they predict that whether in a particular protein which is the unknown sequence, whether particular domains are there or not, whether motifs are there or not. So in case of secondary structure, there are three things. One is the helix, one is the beta strand, and one is the coil. So AlphaFold does very good if it comes to the helix and beta strands, but they cannot do much accuracy with the coil one. The coil is the unstructured one. And also in proteins, there are two things. One is the ordered region and one is the disordered region. So the disordered region many times protein functions with disordered region. So the disordered regions are mainly the region which are flexible part, they are not fixed basically. So the AlphaFold, as I said, that when they train that within a protein, what are the motifs are there, what are the domains are there, they learn the folds or they learn it from the known structures, where the structures is there and the sequences are there. To learn from there those things. And once they learn, if you give the unknown thing, they see that whether the sequence with the known structures is present or not. So in this way they predict. And they do very good with the high accuracy in case of coil region. No, in the part of the beta strand and the helix part, but they fail in the coil region basically. The coil region is unstructured for it. So actually, if you look in this particular picture, so there are many parts are given here, and if you see these are helix are shown here. So helix stands. So this is stand basically. I was talking about stand. So this is stand basically. So this is stand. This is helix. So they do very good in predicting because of any, as you know that there is evolution concept is there, no? So the proteins are involved and there is a called the homoplasy and so all of those things is there. So if the sequence is conserved, then the structure will be conserved. So they use those concepts. So coming back to machine learning again, because majority of the people, when we use AI, we use machine learning basically, which covers mainly 70 to 80% AI covers in the machine learning part. So in case of machine learning, there are two things: one is supervised, one is unsupervised, and within supervised, there are two things: one is the classification and regression. So many times when I teach to my students that people know machine learning, people know what they want to do, but they don't know when to use classification and when to use regression model. So the question comes is that we know machine learning, so when to use classification and when to use regression. And when you know the labels basically, so whenever you know your sequence, suppose your label is known, so label states that whether it's a yes or no. So if it is a yes or no, or if it is a binary form 0 and 1, then you can go for the classification model. If you have a continuous numerical values, for example, within 0 to 1, it can be 0, it can be 0.5, it can be 0.6, 0.7, it's a continuous numerical values, then you go for the regression model. And if you don't have any, if labels are missing altogether, then you go for unsupervised, which is mainly a clustering. So the basic concept is classification, regression, and unsupervised learning. Besides that, there is another one which I will talk with. This is more like agent-based learning. So, okay, so now the steps. So what we do when you want to do the machine learning? First thing, you have to load your data. That data can be in a tabular format. And you have to split the data. Generally, what we do basically, there is a training and a testing concept is there. You have to train your data, and then you see whether the model is good or bad. Then you have to use a testing set which is not using training and testing, and see whether your model is perfect or not. Then once you develop the model, we have another data set which is called blind data set. So generally, when we develop machine learning, so the data set is very important. So first thing is that data set has to be divided into three parts. One is your training and testing, and one is the blind data set. So blind data set is a data set which is not used for training and testing purpose altogether. that is called as a blind data set, or also use another term called independent data sets. So independent data set and blind data sets are very important. Why? Because when you train your training and testing, the model will perform very good. But when you use a blind data set, then the performance of the model goes down. But when you publish a paper, or when you communicate with others, we generally talk about performance measure not on the training and testing, but on the blind data sets. Because blind data set is a subset which is not used in the training and testing purpose. Okay. And finally, how to say that whether model is being good or bad, we use some performance measure. So performance measures can be divided into two parts. One is the threshold dependent and one is threshold independent. So when you talk about threshold dependent, we talk about called accuracy, sensitivity, specificity, and when you talk about threshold independent, we talk about ROC plot, which is the area under curve. So many times, if you don't understand all the things, but you have to understand two very key things. One is the sensitivity and one is specificity. What does it stand? Sensitivity means when my supervisor taught me that over these two terms, sensitivity means half a half. If it is yes, can you say yes? That is a sensitivity. And specificity is na to na bolna. If it is no, can you say no? So if you understand those two things, because it is widely used term, sensitivity and specificity. So it's a false positive rate and it is a false negative rate. So you have to understand those two terms. Suppose I am giving an example, so it may or may not be suitable, but you can understand how it works. Suppose we have a data set and we have an M in different forms and W in different forms, for example. So if we take it as a M, first one is +1 and +2 in a different W form. So what we do in machine learning, typical machine learning, is that we divide the data into two parts. As I said, one is the training data, which is 80% of the data shown here, and one is the testing data, which is 80% of the data shown here. And some part of the data, as I said, we term as a blind data set or independent data sets. So we use this training and testing to develop the models, and suppose we use some CV, that's for the cross validation technique. Maybe it's a 5-point CV, or we can use 3-point CV, or we can use lead one-out cross validation technique. And finally, we use the term for accuracy, sensitivity, specificity, and then also use the same thing for the blind sets. So when you talk about the performance measure, we talk about two types. One for your training and testing, and one performance measure for your blind data sets. So this is very important. The performance measure of a blind data set is important, then the performance measure should be your 5-fold CV. Understood? So when you talk about the performance measure, when you read a paper, you see the two types of performance measure comes. One for your training and testing purpose and one for your blind set purpose. So what is more important? Important is the blind data set. Because why? Why? Because your model is not really seeing the data. So whatever the data you are getting, the first time they are seeing it and you are predicting. So if the performance measure is good in a blind data set, then only you can say that your model is good. Sometimes what happens when you train your data in your training and testing purpose, the accuracy comes around 90% here. The accuracy because of 5-point CV, when you do training and testing, maybe the accuracy is 90% here. But when you use a blind data set, the accuracy may come to 70%. So there is a huge drop in the blind data sets. So when you publish a paper, or if you communicate with your with the person that what is your how your model is performing, so you have to say the performance at 2 times. So this is an example you need to understand very carefully, and this is a class of the data, how it looks like. Suppose this is a sample and this is age, WC, NLR, AST, albumin, GA, and CRT. So they are the blood parameters basically, and these are the patient name given here, and these are the CT scan scores, and these are the risk of severity. So if you look at this data, so what does it mean? This is one patient basically. This is a vector basically. This is one vector. Vector consists of 7 features. 1, 2, 3, 4, 5, 6, 7. So what is the vector length here? Vector length is 7 here. And the labels, there are 2 types of label. If you look at the CT scan score, the label is 11, 5, the risk of the severity is 1. So suppose here the labels are given in two types. One is the one in the format of 0 and 1, and one in the format of numbers with the numerical numbers, continuous numerical numbers. So can you tell me that if I want to use these features, and if I want to use the risk of severity which is 0 and 1, what type of mode of you want to go for? Whether you go for classification or regression model? Classification. So if the labels are continuous number, then the regression model. So you understood. So you have to understand the data and you have to understand the label, and then you have to go for whether you go for regression model or you go for the classification models. So only thing what you need is that you need a vector basically. So in this case it's a small vector length, it's 70 meters. So I hope everybody understood. So there are two terms that I used. One is the features. To understand the feature, this is the features basically. And these are the labels, and within the labels, and there are some continuous codes, and there are some in a binary format. Okay. So once we have this data, maybe in the CSV format, maybe in a tabular format, you can upload it in your machine learning mode. So the another term we come across in machine learning is called CV. So CV is not your CV, but not my CV, it's a cross validation. So generally, when you come in CV, we divide the data into maybe how many times, 5-fold, 3-fold, or in a jackknife model. So when you use the training and testing, the CV is very important. So what does CV mean? Suppose if you want to do 5-fold cross validation, suppose there are 100 samples are there. So 100 divided by 5 is 20. So there will be 20 subsets. So there will be 5 subsets. Sorry. So out of 100 samples, if you use 5-fold CV. So it will be divided by 5, and then there will be 5 subsets, and each subset will have how many samples? 20 samples. If you use 3-fold CV, then what will happen? It will be divided by 3, it will come to 3. So you understood. So in case of k-fold cross validation is very understood that once you use the term for training, you don't use that part for the testing purpose. For example, so suppose in this particular part, if the test is shown in a, if this is a testing and if this is a training part, so whatever you use for your training, so that should not be used for your testing purpose. And you should rotate your numbers. Suppose for example, if the numbers has been not been arranged properly. Suppose whatever the things which will be used for your training should not be used for testing. That was the overall idea. But many times, sometimes the data set is very small. So if the data set is very small, then we don't go for 5-fold or 2-fold CV. We use a called leave or cross validation. What does it mean? You just leave one of your data, sample data, and use the other data for your training purpose. So if we use this particular purpose when your data set is very small. So again, the overall concept is that you have your training testing data. You put your if your model, if you are training and testing, then you develop your model, you train your model. Then this is the blind data set. Again, you test it and you predict it and see what are the performance measures. So what happens when once you have your training testing, and there are two things. One is that you know the labels, and one is the predicted labels. So once you know your labels and once you predict your labels, you can use the 4 terms which is called true negative, false positive, and true positive, which is so near. So this matrix term is called confusion matrix. Wants to confuse you. So the overall part is that this is the actual. Suppose this is negative and positive, and this predicted is negative positive. If both are saying negative, negative is a true negative, and similarly if both are positive, positive is true positive. So if you use this, the overall idea is that if the model is good, these parts should be high. The true negative and true positive should be high. If the model is good, and if the model is bad, then the false positive and false negative should go high. So looking at a confusion matrix, only you come to know whether the model is good or bad. And you can use these terms, the true negative, false positive, and false negative part. You use these terms and then you come up with something called sensitivity, specificity, PPV, accuracy. You are using those terms from the confusion matrix and you are coming up with the performance measure for accuracy, precision, recall, specificity, and also come up with the matrix correlation condition. So these all the performance measure we use while using classification based model. However, when you use the regression models, we use a different performance measures. We use the mean absolute error, we use the mean square error, and also use R squares. So you need to understand that if you use regression models, you have to come up with these performance measures, and the error rate should be low. And if the error rate is low, then it shows that your model is doing good. So all the things, as I said before, whether I say accuracy, sensitivity, specificity, they are all basically threshold dependent. So the overall idea is that if you look at any model, they give a chart which is called the receiver operating curve, or it's called ROC curve, and the ROC curve give a picture of area under curve. So the more weight is, the more the area under curve. And if you look at the dotted line, this is a random classification. Suppose your accuracy is 50%, then this is what it gives. This is a particular area angle, this is a random classifier. And the more it tends towards in this direction, the accuracy is high. So in the x-axis, if you look at the figure, it's between 0 to 1, which is the false positive rate, which is nothing but the sensitivity. And if you look at the y-axis, again, it's between 0 to 1. It's a true positive rate, which is say 1 minus specificity. So if you want to look at ROC curve, what does it mean? X-axis is sensitivity and y-axis is 1 minus specificity. And both stands between 0 to 1. So this is a very important slide for people who doesn't want to do programming but still want to do machine learning. So believe me, there are several tools are available, and most widely tools are the Python tool, which is a scikit-learn. Generally, in my lab, my student uses the scikit-learn. And there are some PyTorch, TensorFlow, and people like biology students, they want to do machine learning, but they don't want to do any programming. For them, Vika is very important. So Vika uses Linux, Mac, and OS Windows systems, and it's a Java-based thing. So it's a software-independent part. You can download Veka in your computer and you can do all the machine learning which is available. So coming to the Veka, it's a very tool. As I said, it's a Java-based tool. So you can download in your normal PC. And can anyone tell me which part it is?
Kiwi.
Kiwi, very good. So the data is found Kiwi?
New Zealand.
So the software was built in Auckland. So that's why they gave the Kiwi and they take the University of Waikato and they developed these tools. And believe me, many people use these tools. And it's very straightforward. You have to download it and you have to upload your data, you choose your whatever machine learning you want to do, you choose your what type of CV you want to do, computer matrix will be generated, then you can upload your blind data sets and you can do all sorts of machine learning. So just I will give you one thing. So suppose this is what, once you open it, if there is an open file, the open file allows you to upload your data, it can be in a .csv format or in another format. Once you upload the data, you can see your data, and then if you go to the classifier, if you choose the menu for classify, then all the options will come up here. It can be knife based, it can be SPA, whatever the tools, which can be artificial neural network. So once you choose the classifier and you choose your program, suppose in this case I choose knife based, and then you have to do your training set, and then you have to choose that what type of CV you want to use, as I talked about. It can be 5-fold CV, it can be 3-fold CV, it can be jackknife, which is a G-corner cross functions. So you have to choose your CV first, and then once you choose your CV, you upload your data, and then you get your performance measures. So these performance measures is what you are getting for training and testing. It's not for the blind data set. So as I said again and again, the performance measures come 2 times. One is for training and testing, and one is for the blind data sets. So these performance measure, so the conclusive matrix is generated here as you can see. So we understood that these are the false positive and true positive and true negative. This is a diagonal I was talking about. If this diagonal number is high, means that model is doing good. Okay. And this part, the opposite diagonal is basically false negative and false positive. So that has to be low basically. To see whether the model is doing good or not. So looking at a conclusive matrix only, you can come to know whether the model is doing good or bad. So again, as I said that the overall goal, so this is what I was talking about, that the conclusive matrix part was what you need to see. And based on that, you can compute all those true positive rate, false positive rate, PPB, recall, F measures. So the vector does all the things. Vector compute all the performance for you. So only thing what you will do, you have to choose your model, you will upload your data. And you have to choose which particular machine learning you want to use. The conclusive matrix is generated and you can interpret your data as well. But finally, as I said, that you have to choose your blind data set. Then you have to supply the test data set, which is a blind data set, which has not been used for training and testing. And then you have to save your model. Because once you choose your blind data set, it has to be a model. So you have to save the model and you call your model and put your blind data sets. So once you put your blind data set, again you are getting the conclusive matrix. And again you see that the conclusive matrix, this particular diagonal which holds for true positive and true negative, this is high as compared to the false positive and false negative. It means your model is doing really good on the blind data sets. Looking at the conclusive matrix is not good. So we have to do two times. First, developing the model, save the model, put your blind data set on your saved model, and then again create the conclusive matrix. And then again you get this all the same things. True positive, false positive, PPB, recall, results, and as well as the RRRC, which is close to 1. So you get all the conclusive. So this is what about machine learning, and as well as the question of just framed in the very beginning that can a biologist do machine learning or not. Although this is very I think last to last year, but believe me, in the PubMed where they talked about only biological sciences, you see the huge amount of hits you are getting to use AI or machine learning. So in PubMed generally it's not a IEEE paper, it's a PubMed. PubMed generally talks about biology paper. So you see a lot of hits are getting up around 1 lakh hits, approximately 1.69 hits where AI or machine learning is used in the biological physics. So it means that normally a biology person who are not properly trained in AI can also use it. They can also use machine learning. The only thing we have to understand is that which tool you have to use and how it will interpret the data and how it will interpret your performance measures. That's what we need to understand. So any question from this part? Because now I will be switching over to my work. This is more like an introduction part. Yeah.
What is the difference between identification and classification?
What is that?
Difference between identification and classification.
Identification classification. Generally, we don't identify, we generally predict basically. When you talk about machine learning, generally we predict. When you do some experiment, then you identify basically. Suppose you predict something and then you put your experiment and then you say it's really what you validate it and then you say that you identify it. Otherwise you always say we predict, you don't identify. Any question on this part? If not, then I'll switch over to the next part. So to summarize, because I was asked to give you the 5 questions from this particular talk, so the important thing that take home message is that so there are some threshold dependent measures and there are threshold independent measures. And within threshold independent measure, what was the performance measure? Threshold independent plus ROC plot. So how the ROC plot was generated? What was the x-axis and what was the y-axis? So 1 minus and sensitivity 1 and 1 specific. Good. And what is Rebecca?
For biologists, which allows us
This is Java based. Simply Java based programming. Okay. Java based. And when to use classification and when to use regression model, if you have a data with a label, if you have features, then you have
when we have going for regression and with the discrete data, then we will go for classification, and if you continuous data, then we will go for
very good. So the take home message is at least you can answer those things. Very good.
So whenever we are using continuous data, we are going for the regression, and in that case, we are seeing the different type of errors.
Exactly.
So whenever the error is minimum in the training case, and after training the model, whenever we are feeding another blind data, then also we have to see whether the result error is minimum or not.
Exactly. Very nice. Very good. So in case of regression model, what are the performances that you use?
MLC and
And right level R square. Middle level R square. Good, very good. I think concept is very clear now. So now moving to the research work what we do in our lab. Okay. So the question was the development of disease using AI. The question was, can AI predict disease or not? Or in a different way, can we automate the diagnosis process using AI based on symptoms as done by the physician? As I was saying that when you go to the physicians, the patient talks about symptoms and the physicians give some drugs. Okay. So can you automate it? Or in such a way that if you give the symptom to the, if you put symptoms to the model, can the model predict the drug or not? So that's questions we have on hand. So before that, I just talk about that in my lab we do focus on the pulmonary diseases. So as you know, in the post-COVID era, lung diseases require continuous medical attention. And lung diseases are also hard to diagnose. Why? Because there are several types of lung diseases, and if a patient comes to the doctor, they talk about the type of cough and I have a difficult. That's the only thing they can say. Because it's a non-invasive way. And then because doctor cannot look at exactly what lung looks like, only thing they can take is that they can take stethoscope, take the heartbeat or something like that, or they can use a taste for the spirometer. I hope everybody knows about the taste for spirometer. You have to cough it and within 1 second how much breathe you can take out. So these are the taste. The other taste are like somebody suffers from TB or tuberculosis, then you have to give those sputum samples. So these are the two things. But somebody is suffering from cancer, which is a lung cancer, or somebody is suffering from the pulmonary fibrosis, because pulmonary fibrosis is very common in the post-COVID era. So people suffer from, many people suffered and they died due to the pulmonary fibrosis. So for that, what you have to take? You have to take the sample, lung tissue samples. How? You have to make a cut here and then take the tissue from the lung tissue and see what's happening. The other way around is that you can take CT scans. Then we can use CT scans. So CT scan is good, but the charge is very high, around 8,000 rupees. But many times a patient, suppose a patient which is a aged patient, and they go to the hospital, they do one CT scan, and the problem with the CT scan is that you are exposed to X-rays, and it's not quite ethical to take CT scans maybe after next week or maybe after 1 month. So we have to wait. Maybe you can take CT scan maybe 6 months, after 6 months you can take one time at a time. And for the patients who are very ill, it's not at all wise to take CT scans 2 or 3 times in a month. For example, suppose a patient is suffering from pulmonary fibrosis. First time they went to the hospital, they took a CT scan, But if you want to know that whether the drugs are working or not, whether the lung is doing good or not, then what you have to do? You have to again take a CT scan, but it's not allowed because he or she is already exposed to CT scan once, and it's not wise to take CT scan maybe after 6 months. You have to wait for another 6 months. But believe me that the pulmonary fibrosis is such a disease. It works drugs or because there are only 2 drugs available for pulmonary fibrosis. Only 2 drugs. So we don't know whether it's working or not. If it is inflammatory, then it's okay. Then you give some steroid, you just stop the inflammation. But if it's a fibrosis form, it is very difficult. So you don't know what's going on in your lung, and it's very difficult to take subsequent CT scans. So can we do something? So maybe can we take the blood parameters and can we predict that what will be the drug, how is your lung looks like? So that was the question what we had in our hand. So the question is very simple, that can we predict lung health using the clinical parameters like the blood parameters? That was the overall question. So I hope I framed the question to you. So believe me, lungs can be broadly classified into 4, and there are many other subclasses are there. So mainly obstructive pulmonary diseases where the asthma, COPD are very common, bronchitis also falls in this particular class. And there is a non-obstructive pulmonary disease, which is the ILD is a bigger picture, but within ILD there is a IPA, which is the pulmonary disease, which is coming here. Infectious disease, COVID is partly known to you all, TB falls here. And the 4th broad category can be the lung cancer. And believe me, out of all lung diseases, the obstructive and non-obstructive pulmonary disease, or you can say obstructive pulmonary disease, consists of nearly 70 to 80% of all the lung diseases. So most of the people suffer from asthma or COPD or bronchitis. You understood the problem. So, and what people, doctors do, if it's a clinical investigation, they go for blood test and spirometry I was talking about. And radiological investigations, you all know, chest X-ray and CT scans. Chest X-ray nowadays people don't do generally. Why? Because if you take the chest X-ray, you just get, suppose you have a book basically, and if you take a chest X-ray, you just get the picture of the front page of the book only. This is what X-ray does. And if you take CT scan, then you get all the pages of the book. So you understood. So doctors want to read all the pages of the book, so they go for CT scan, they go for X-ray. Both are equally bad. Both are get explosive X-rays. But because it's a better way to read all the pages of the book, so that CT scan is very popular, and it's very costly also. Suppose X-ray nowadays cost within 200 or 300 rupees. Now we can get X-ray within 1 hour. You can get the X-ray. But CT scan, it takes some time, and you have to spend some time. And then the other point with the CT scan is that is very difficult to interpret also. So there are some white scars will be there in CT scans, and it's very difficult to interpret. For example, if the person is suffering from pneumonia, you get a lot of scars are there. And suppose a person suffering from pulmonary fibrosis, a lot of scars will be there. How do you differentiate pneumonia and fibrosis, pulmonary fibrosis? In case of pneumonia, if the doctor prescribes some antibiotics, all the scars will move away. But in case of pulmonary fibrosis, the scars will remain. So you understood the problem. So it's not very easy to interpret the CT scan.
Both are the GGO and ground glass capacities that
Yeah. So you understood that it's very difficult. So, and the genomic investigations nowadays people generally do, they go for they go for gene expressions, like they see which are the features or proteins or genes which go up, and also they look for whether there is a mutation, specific mutations are present in the particular gene or not. So these are the broadly people use clinical investigations, biological investigations, and the genomic investigations. So the first is that I will cover 3 stories today. So due to the constraint of time, And the three stories are, first story is that can we classify the obstructive and the non-obstructive pulmonary disease using spirometric features. Spirometric features are very common features. If you go to any hospitals where the pulmonary setup is there, the spirometric is there. And it's a non-invasive way, because people generally prefer non-invasive way. So you just give a puff and within 1 second how much volume of the lung is there, you will not know. And they will do 2 times before taking one drug, which is called orbital generally. Before orbital and after orbital, you have to give your post-expiratory volume. The first questions come first. So can we differentiate between obstructive and non-obstructive? Why? Because the drugs which is prescribed for the obstructive pulmonary disease are different in case of non-obstructive diseases. So you need to understand first, and the first thing first, what doctors have is the spirometric part. And once you have the spirometric data, and if you want to have the label, I hope everybody now understand what the label is. Label is obstructive or non-obstructive in this case. So there are labels, it's a 0 and 1 case. So can we have, and having all the spirometric data before and after sorbitol, which is a drug given to the patient generally, and we have the two data and we have the labels, and we develop models. That was a question. So this is how it looks like, that you have to pop up and generally they give one drug basically, and you have to pop up 2 times, before and after the drug, and you have the data. And once you have the data, it's all been printed out and you have all the data with you. Okay. So this is what, and why it is used, because as I said again and again, it's a non-invasive way, and it measures the volume and the speed of the airflow of the lungs. So as I said, once you give your pump up, it comes up the force vital capacity, the force expiratory volume 1 means 1 second, and force expiratory volume which is 25 to 70 percentile. We come up with all those data sets, and we used it. And there is a hospital close to our institute in the New Town. It's an Institute of Pulmonary and Research, and they gave us some data of patient data with all the force data, and they gave us a label also. Label means whether they are suffering from obstructive or whether they are suffering from non-obstructive diseases. The problem here is that as I said, most of the people are suffering from obstructive pulmonary disease. The data is very high. The percentage of data which you obtain for the non-obstructive pulmonary disease is very low. The ratio is 6 to 1. Usually, in case of real life, always face this problem. It's not that always 1 to 1 data we have. We always have imbalanced data. And similarly, we use another set of data, as I say, again and again, when we develop model or AI or any deep learning, we always have 2 data sets. One is standard data set, which is called blind data set, or independent data sets. So we have
this group is for blind data set.
Yeah, we have to always keep the blind data set in one model, otherwise nobody will believe in your model. Because why? Because sometimes the inner calibration comes into picture and easily, and some overfitting comes into picture. I hope you understand what does it mean. So that's why nobody believes in your performance whether it comes to your 5.0 or 3.0. So overfitting problem always is there, and that can be ruled out in the blind exercise. So we had all this data with us, and we thought what to do with it. So if you look at this data, it's 1000 versus 1006 is approximately 6:1. So what to do with this data? And in real life, we don't always have the scenario where everything will be good to you. You have something in real life situation. So what we did was, I think something happened. So what we did was we divide this problem in 2 ways. One is this is the problem which is the data set group A, where we use normally as it is 6:1, whatever it is. But here we got this sampling. Sampling means we use this the obstructive pulmonary data into 6 parts and divide into 6, and 1/6 of the data is present here. And since the 166 data which is coming from the non-obstructive disease, we put it in this paired form. So what is happening here in this particular cases, which is the sampling cases, what it did was this is the negative, means in this case negative stands for the non-obstructive pulmonary disease, and we take one subset out of 6 basically in this part, and we have M1, M2, M3, M4. So in this way, we perform a sampling based method, and the other was a normal method where we use the data as it is 6:1. And we performed all those similarly methods and developed sensitivity, specificity, accuracy, and similarly we performed in group A, and we use the group B data which is shown here for validating the models. Generally, when we use machine learning, we need to understand that we use different parameters grading. For example, if you use SPM, there are many things comes into picture. For example, in case of radial basis, we come up with some parameters for C or gamma. So we need to change or tune the parameters. So generally, if you know a little bit of programming, then you can choose C in different format. Or in case of gamma, you can use different format one time only, and in this way you can train your features. Similarly, the random forest trees, and in case of MLP, there are, as I said, for machine learning, neural network, you have to choose the layers and nodes. So in this way, you can choose all those things and parameters reading by putting an array or maybe putting a for loop, and you can tune your data. It's not that simple also that you choose one parameter only and get optimum model. You have to optimize your model based on choosing different parameters. And you have to pass the parameters, make sure that your model is optimal. I hope I get the message to you. It's not that one parameter your model is ready. You have to tune your parameters and make sure that you have searched the grid basically. Grid means all the space. All the space of the parameters you have to search it and make sure that your model is okay. So this is how it looks like, and this is the data which is the old data sets where you don't do anything, the 6 data and 1 data. And here where you have done some undersampling, that we divided the obstructive pulmonary into 6 part and took 1 part and as well as the non-obstructive part. But in this part, what you can see in the undersampling part, the sensitivity specificity performs better as compared to the old data sets. So it means that if your data set is unbalanced, then it's better to go for undersampled models rather than looking at old data sets. I hope you got the message. Similarly, in case of blind data set also, we can see the performance of the undersampling method is better as compared to the old data sets. So if your data set is biased, it is better to do some sampling or undersampling rather than taking as such. Again, as I was looking at the data, you can see that the performance measure was obtained around in case of we chose different machine learning, and we chose MLP. This stands for multi-layer perception, basically artificial neural network. Basically, we perform that MLP performance is better as compared to SBM and other machine learning models. And again, you can see the plots here. Again, we talked about again and again the false positive rate, which is sensitivity, and the false and the true positive rate, which is 1 sensitivity, and performance plot, and higher the plot towards this, we got area under curve and area under curve towards here. Also, you can see the area under curve is higher as shown in the threshold dependent measures. So what we do in our institute, once we have the model, we don't leave as such. We have a web portal. We keep the model as such, and if you give your input, it will go and keep the model and you get the output. So everything is online. So just we have to go to the resources, Bose study, Palmograde. You can see the data, and if you give your flow calculator and post calculator equity volume, you get the output. So the model has been used in a web portal, and once you give your data, the data, and you keep the model and you get the output results. And it says that whether it's obstructive or not, or what is the probability value shows here. So you get a probability value also. If the probabilities are loose, everything is high, then you are very much confident that it's obstructive or not. So coming to the second part of the story, which is the radiological image and clinical data analysis for long disease rates of COVID-19 patient data. So So any questions from here? First one.
So, Palmocrate, is it available on your website?
Yeah, it's available online.
It's more like the application where we can take the data and get some outcome. We can also use that.
It's available free. We didn't go about patent or we didn't go any. We just published it. Is what we do generally. And yeah, it has been published. And yeah, it is free. Okay, so coming to the second part of the story, it is very interesting basically. And as I said that I talked about the radiological image, which is nothing but CT scan data basically. And the clinical data is the blood parameters. Blood parameters is easy to take. You take the blood, and nowadays people come to the home also to take the blood. And so what happened because of COVID-19 time, huge amount of data was generated where they have had the CT scan data as well as the blood parameter data. They published a paper in Nature Communications, and all in 2020. So what we had basically the image data, CT scan data, and as well as the blood parameter data. So we thought why not use this data and develop a model. So because once we have the blood parameters, the values are there, and images are there, why not develop a regression model? And regression models will allow you to predict what is your lung looks like. So to give you more detail about lung, so lung has 5 lobes. So right part there are 3 lobes and left part there are 2 lobes. So there are 5 lobes are there. So because generally when we taught in biology, so plus 2 we say that our body is symmetry but our body is not at all symmetry. So it's a 5 and 3. So generally when people do CT scan, so they take the lobe, each lobe, and they mark for 5 marks each. So based on, as somebody was saying, that scar, how much scar it is. So based on that, they mark scar and compute a value, and then they say that 1 scar has 3, 1 scar has 5, compile all those 5 scar, and they come up with scores. So believe me, like our brain, we also don't use our lung properly. So we use only maybe 40% of our lung. So most of the lungs we don't use it at all. Maybe the sports person they use it, but as a common thing we don't use our lung. So all the 5 are not really used. So what happens basically, as I said, that the distribution of the opacity is not equal in all the lungs. Some lungs will be more, part of the lobes will be more affected than the others. So what we do, we just sum up with all the lobes and come up with score. So what happens basically, since we have the CT scores, we have the CT scan data as I said in this communication. So we have all the 5 lobes, each doctors or the radiologist can compute the score. They compute for each patient, CT scan is there, 5 lobes are there, they compute the scores based on the opacity and spiral like formation and all those things, and come up with the score. And same patient has the clinical data, like how much albumin it is, what is the NLR, and what is the CRC protein, and what is the CRC protein. So there are, like that, there are 12 or 15 features in the chart are there. So now we have the data sets published by Peng et al. The CT, with the CT score, I hope everybody understands what CT score means. CT score is the form of all the scores or coming up with the values for all the 5 lobes, and the maximum will be score will be 25, 25. So the maximum will be 5, and minimum will be 2 if somebody is too good or lung is not affected at all affected. So based on that, I have all the values of your parameters like CRP, albumin, and also age is a parameter which is very important. So the overall story is that we have the radiological data and we have all the clinical data with us. So can we do something? So what we did was we took the CT scan data, and as I said that we use a regression model, and we tried to find out that whether the lung health severity is there. And lung health severity, suppose as I said, the score will be between 0 to 25. If suppose the score is above 14, then you can say it's a very severe, and if it is less than 14, then you can say it's a low risk. So the overall goal is that we use those data sets where all the CT scan data with CT scores as well as the clinical data are available, and we use it in our model and use regression model. I hope now the audience understands that why use regression model. Because it's a continuous from 0 to 25. So as I was talking about, so when this paper was published, they used huge number of parameters, blood parameters. I think they started with something 15 or something like that. But what we found that there are several parameters like, as I said, albumin and AST, the neutrophil to leukocyte ratio, the LDH, the CRP protein, the white blood cells. These features are very much good enough to predict the CT score. Just we just use it and we found that, and also age is a parameter. So there are many parameters published in the paper, but out of that we found the seven parameters, the base parameters, which allows us to predict the CT scores. So out of these, you remember age is one of them, and the remaining are the 6 parameters. So what we did was we choose the blood. As I said, the blood is there, and the blood we got 6 parameters, as I said, and we had a CT scan. And again, but in this particular work, we split it into 90% into 10%. And I hope 10%, what does it mean? 10% means it's a blind data set. I hope that you are, I am telling again and again the same story. So it's a blind data set. You have to keep it, otherwise nobody will believe your model. So this is the blind data set, and we use 10% or 90% data we use, and we use regression model. And again, as I was telling, for regression model, the performance measure would be MAC, MAE, and the R square values. And again, as I said, that you have to select the grid, basically the space. What are the parameters are there? For in case of MLR, SBM, and SBR, these are all parameters. You have to choose your grid. Make sure that you optimize your model, and then you use a performance measure. And what we found in case of 3-fold, 5-fold, 10-fold, these are the ME, MSC, and ACC values. And also same thing with perform in case of same D, which is our blind data set or independent data sets. So by this way, we got the data into machine, and also we go for multi-layer perception, which is nothing but a artificial network. What we found that the 5-fold cross validation because it was better, which is a minimum one as compared to the others. Now the question comes is that suppose you have your data, and this is the plot for the low risk patients, and this is the plot for the high risk patients. So now we understood that the x-axis is between 0 to 25. So 25 means the lung is already affected, basically all the fibers are affected, and in case of this, only the initial part is affected. So these data were trained for the COPD patients where people first time come to the hospitals. So you don't know, the patient comes to the hospitals, or let's say it's a mild infections. So you don't know the mild infections will go to the severity or the mild infection will remain as a mild infection. That was the question. Okay. So when the patient comes, we have the blood parameter and we have the CT scan data. And we have to predict based on that whether the mild patient will go to the severity or the mild patient will remain as mild. If they don't need any attention, they need to go home. So that was the whole story. So what we found, our prediction model was good enough, and we could predict with the high accuracy, and which are the low probability and which are the high decisions based on the plot which is shown here. Similarly, what we did was we used that model, the regression model, in our web portal, and we allow users to use this model. And what they have to give the parameters. As I said, the 7 parameters. One is age, and the others are 6 blood parameters, which include white blood cells, neutrophil to leukocyte ratio, AST, albumin, LDH, and CRP. Believe me, the blood parameters cost of these particular 5 things is cost approximately 1,000 to 1,500 rupees. If somebody does this parameter test, the 6 parameter test cost to 1,000 rupees. So they can use these plot parameters and age is known. They can feed it in the model which is available in the web portal and they can get the data. So how the data will come? The data will come something like this. So this is the output file which is shown in a red dot. So if it comes here, then we can predict that whether it's a higher expression or the lower expressions. So according to you, what will be the answer? In this case,
Loading.
load is understood. So if it falls something like this, then it will have this.
Yes.
But the problem starts here. The problem starts here if something falls here. So this is the boundary or window that we cannot do anything basically. If something falls here, something falls here, it's very easy to predict. But a window where the score falls between here to here, it's very difficult to predict. So for that, the probability is very low. Yeah.
Sir,
You will say something.
yes, sir, this is with only the blood parameters
Yes.
and the age factor.
Yeah.
Without the city, we can predict the severity of the lungs.
Because we trained it, no?
Yeah.
And now we are not using it. Because now the model is only used. And now we have to use the platform. That was the idea. Because if a patient comes to the hospital, first time you can have a CT scan, but when he goes home, you don't know how the lung is. You may behave in a very good way, but you don't know what is the lung, how the lung is. So you just take the blood parameters, put it in the model, you know that how your lung is good or bad. So generally, many people die due to pneumonia basically. So it predicts that whether lung health is, it predicts the lung health basically, based on the 6 blood parameters as well as age. Age is important. I hope everybody understands why age is important. Because telomere shortening is there, and how long or all the organs of our body behaves all depend on the telomere, and that telomere shortening takes place when we get age. So that's why age is always a factor that comes to play.
So during this was done during COVID, but did we take those additional disease which the person has? I mean, any other additional disease like hypertension and diabetes that we were saying that those people are at a more risk of getting in future more lung severity. So are we considering those things?
In this case, the answer is no. So that time the blood and the data was used for the payment on paper. So they want to make sure, because COVID was at the peak that time, because the data came in 2020 and we published in 2022. So you can understand that within 2 years time we published. So that time getting a data with a CT scan as well as blood parameters, there are very few papers where both the data are available. So any questions from here? And also as I said that age grade is available. You have to print it and yeah, can you use it. So any question from this part? The student?
Actually,
the last part now. The student is in
The seven parameter, can you say that the 7 parameter will specifically say all the status of our lungs? Is it true? Or we need some other parameters also?
So when Kolkata published the paper, they used approximately many parameters, like 35 parameters on the lung, of the blood. But when we use and we see that what is the correlation between the severity score and the 35 parameters, we found that these 7 parameters, the correlation was very high. So that's why we do all the parameters. Because if we ask the patient to be 35 parameters, then it's not feasible. No. So if you ask them to do all the figure parameters and we have to use a minimalistic model. So minimalistic model is minimalistic features. So that was the whole idea. So they published 35 parameters in the lab, but we went faster away because they knew.
Sir, I have a question. In the classification model, we used only 2 classifiers, okay, 2 classifications. Can we increase it to 4 to 5 at least so that our prediction will be more accurate and the patient will actually know in which direction he or she has to go? So to incorporate this, what should he do?
In case of here,
Here.
so there is an option called, so here what we do basically we are using a regression model. And if we are thinking that if the score goes above 40, then we say this is severe, and if it goes below 40, then we say it's non-severe. So we are using regression model, we are not using classification model.
So we can switch to classification and can increase the number of classifiers.
Because here you cannot use classification model because you get the CT scan value. No. CT scan values between 0 to 25.
That I know, but here it remains a limitation because only two types of predictions you can do it.
So here what we are predicting is long here. Long is good or long is bad. We are not predicting a disease or something. That's what we want to know now, whether long is good. Because CT scan, what does CT scan do? CT scan doesn't predict the disease. It can predict the radiologists which are very expert, they can do it. But then we say whether long is good or long is bad. That's what we are trying to do. In case of multi-class, it doesn't suit here. So multi-class, we use multi-class. So if the problem, for example, you can give an example of, suppose in case of cell. So if you want to see a protein, whether the protein goes to the nucleus, whether the protein goes to the nuclear membrane, whether the protein goes to cytoplasm, or whether the protein goes to the outer membrane. So there are 4 things. Then you can use multi-class. Example I am giving you. So the multi-class can be 0, 1, 2, or as I say, cytoplasm nucleus. So we can use multi-class. So this is what we generally do. If you choose 1, for example, then the 0, 1, 2, 3 will be your negative cells. Makes sense. If you choose cytoplasm as a positive, the nuclear membrane, and the other part will be the negative cells. So in this way, create the model.
I have a question. So suppose in this case the binary classifier, like whether the health is good or bad, if it is good, but then the severity also is like severity score also I think you are predicting, so that
No, here we are getting the severity score only. We are not predicting
good or bad. So depending on
good and bad, we just choose the threshold. Threshold is what. I didn't show it here, so we just did some work and we come up with this. But again, as I said, that if something falls here, it is very difficult to predict. Very severe amount. But if it is very extreme gaining, it is very easy to predict. It's a regression problem, it's not a conservation problem. But then what we did was, because people are more interested in good or bad, yes or no. So then we come up with a score and the result was approximately.
But I think the effectiveness of this model is much more better than the binary classifier.
Obviously. Because here we are using the city score.
Yes. It may be good, but it is just below the threshold value. So that means the doctor needs to take care so that it doesn't cross that.
The problem is that if a patient comes with a mild COPD or any pneumonia, it can be COPD 90, it can be pneumonia also. That also it can be predicted. Understood?
Yes.
So we are not predicting the pneumonia or COPD, we are doing long here. Okay, so far so good. Then I am coming to the last part of my story, which is very interesting. And yeah. The question is that to identify the association between symptoms of lung diseases, not lung diseases, we need to all the, I think around 143 diseases, and the drug targets using a drug disease prevention network. Here the question is as whether can you automate the diagnosis process using AI as done by the physicians. So generally what happens in case of data, there is an association where symptoms and disease information are available. Okay. And the disease and drug information are available. So that you can understand. So some data are available. You cannot start from the scratch basically. So you have to start with the data as I was saying again and again. And if you want to use ML, you have to have data. So as I said that these association between disease and symptoms are available, disease and drugs are available. But what is not available between that if you have a symptom, can you predict drug? And that is done by the physician. If you go to the physician, what you do? You talk about symptoms. Dard hai ki nahi, kitna dard hai, how much, what is the strain? If it is a pain, then how much pain it is, or something like that. And can we predict drought? That was the problem that we had in our hand, and we thought of why not work on it. So based on the disease and symptoms, there is a human symptom disease catalog. There is a database is there where it contains all the information. And there is a comparative toxicology database and therapeutic target database. The drug bank is there. Many of you know about drug bank, where they have all the information between disease and drugs. So those information are all there.
These all are available online.
Yes. When they talk about drug bank or something like that, disease database, all available. So the question was that can we predict drug based on symptoms? That was a simple question we had in our hand. Although the question was very simple, but it was very difficult for us to work on it. So the task was to find the existing between the symptoms and disease and drug disease association for lung disease, and to compute a direct association between the drug and symptoms, just which was not there. And use the drug symptom association to develop a ML model for the novel task of symptom-based drug prediction. That was the task we had. And if you look at the matrix, basically we consider the diseases which are, we talked about nowadays, the term is called it's like diabetes, and like the common diseases what we have. So we come up with 143 diseases, which includes diabetes, obesity, the cardiovascular diseases, along with the lung diseases. So we compute all the diseases, and we thought that let us start with 143 diseases, and then we took those diseases and we come across that what are the symptoms are there, and also we took out that how many drugs are there. So it's a term called so these diseases are there is one term is there which are commonly used that like obesity, diabetes, lifestyle disease. Okay. So these are all lifestyle diseases. Yeah. If you look at the examples are lifestyle diseases. People generally come up with all the diseases. So what we thought that why not target for the lifestyle diseases? So we come up with 143 diseases, and as I said that we come up with the two matrix, the drugs and diseases, as I said, on the database for the drug bank, and the symptoms and diseases, and the database is there where it comes from all the diseases. So one thing is common is what is common? Common is the disease, which is 143 lifestyle diseases. Thank you. Okay, so once we had these two matrices, so what we thought, we just compute the similarity between the drug disease and the symptom disease, and we use that. There are many ways you can do it. The most common way is that distance, correlation distance, and the Jacobi index, where you compute the distance between the two things, and we compute the similarities between, and we thought that let's try all the three available similarity scores and see what's happening. And the similarity scores are being used as 0 and 1. 0 is the weakest and 1 is the strongest way. So in this way we compute the similarity scores, and once we have the similarity scores, we started using the clustering analysis. So again, as you know, there are many ways you can do clustering. So why we use clustering based method are the k-means, means, bicyclic k-mean clustering, as well as RCH. So there are many clustering methods. So we had three different matrices based on the distance measures, based on the Bose measures, and based on the Pearson correlations. So we use those clusters models and come up with and scoring system to find out which clusters are properly measured. So how we do it? We use a similarity coefficient based method, which allows you to predict whether the cluster is doing good or bad. Just like normal supervised based method, we use sensitivity, specificity, accuracy, but in case of clustering based method, we use SC to see whether your cluster is properly good or bad. Okay. So once we have those clusters based on different based method, we, as I say, that we use the parameter breeding based method, as I said again and again, that a want to use one algorithm, you don't have to specifically use one parameter, you have to search all the parameters. So we did all the parameter reading search and then all the combinations, we come up with this particular thing. So it's a computer intensive thing. And then we found that when you use a cosine-based method and when you use a bisected clustering-based method, the seniority coefficient is 0.67 is higher. It is 0.9.9 is good, but we come up with a score of 0.67, which is we thought is very good. So it says that the clustering-based method by cosine similarity method and clustering algorithm bisected technique is a particularly better than the others. So what we did was, once we have those clustering-based method, we will make sure it's not only the SC, which is similarity coefficient, but we have to make sure the biologically it makes sense of it. Because at the end of the day, we have to make sure that whether the drugs which are coming within the cluster, whether it makes sense or not. So for that, what we did, we use a chemical structure similarity and also we use a CO. CO stands for the chemical ontology. So we use these two terms, and whenever in a cluster, the same set of drugs are there, we see what is the structural similarity of the drugs which are forming the same clusters. Okay. So suppose for example, you could take these two drugs, although they are different drugs, but you can see the rate portion of the drugs are more or less same. So based on that, we compute a scoring systems, which is called the overlap coefficient, and then we come up with the scores. Similarly, same with the chemical ontology. I hope many of you understand it in the gene ontology terms, which is similar to cellular functions and molecular functions. Similarly, the CO is chemical ontology is a term where there is a parent, child, grandchild, all these information are there. Based on that, we can make sure that whether the two structures, whether they are close or not. The similarity can be obtained. So once we have those mathematical clusters, we group those mathematical clusters and we use the chemical structure similarity as well as the chemical ontology to find out whether the cluster makes sense or not. So what we found in the first panel, you can see the rate is a random one, and these are the clusters we obtained. So we obtained several clusters, and each cluster there are several drugs are there. And if you look at the overlap between the coefficient, between the overlap coefficient, which I shown in the previous slide, which is the formula between the C minus B, A minus B. So we found that most of the 93% of the things are above the random one, which is in the rate. It means the clusters which are drugs which are put together in similar clusters, they are very much similar. Similarly, we use the CO. CO stands for the chemical ontology. Again, we found a similar type of data, and this is a random one, which is shown here. And we found that 89% of the data they are above random, which is 71 out of 80. They are 74 out of 80. So it means that whatever the measures what they perform mathematically, they are not only good for SC, which is performed by the ontology scoring, provided by the CLOT coefficient based method, but also biologically or structurally it may make sense. So this is what conclusion we can draw. Again, so there is a web-based application is there. So suppose somebody wants to give the symptoms, which is shown here, and also the severity of the symptoms. Suppose 1 to 9, 10 is there. 0 means there is no symptom, and it is 1 or 4 or 5. The severity of the symptom is given there, and then you can get the output. And in the output, as you can see, you can predict exactly that which drug you need to do. So the whole idea was that as physicians do, you give your symptoms and you get your disease predict. This is how the server works. And again, it's freely available. But the only thing is that don't go for it. Once you know these things, you have to talk to the physicians. Don't use it as a in silico doctor. It's better to talk to your doctor. The good thing is that I am in touch with doctors and physicians who works directly with the pulmonology laboratory. So I told them previously many times there are some complex symptoms are there. So what does it mean that nowadays people suffer from many symptoms, and believe me, doctors who are aged under 60, which means they are very experienced doctors, they still get confused with so many symptoms. So for them, this AI-based method can help them to differentiate whether what they're thinking and what direction comes. And also the which drugs need to prescribe. So believe me, many doctors are very specialized and they prescribe only few set of drugs only. But if you look at this database and the huge number of drugs are available, and they can come up with generic drug as a more optimum in this case.
But sir, if I have some other kind of diseases along with this?
So generally, since it was a computer-intensive task, this task is very intensive computer. We only want particular lifestyle disease. Because nowadays most people suffer from lifestyle disease. So that's why it's a small part of work, but it can be extended to bigger part. I think for the others to do it, people who are very high intensive computer and do it. But the proof of principle it was. And most of the people, as I said, that 70-80% people suffer from the lifestyle diseases, as she has actually provided. And also we use paper also, but we're not coming up with the term. So it is how it was. And believe me, the drugs, what they are predicted is, I think, that also give the confidence that whether the drugs that they are saying whether they are similar type of activities or not. And many times people suffer from comorbidities nowadays. Comorbidity means that it's not that one diseases. They suffer from multiple diseases, many diabetic patients, and it's very difficult for doctors also to find out what is the real cause. For example, I can give one example. So there are many diseases nowadays coming up, but doctors they didn't learn in their when they got their degree. So there are many diseases out there. Similarly, for example, the NTM is a disease which is called non-tuberculosis NTM. TB is there as an NTM is another disease. It is coming up in the very developed countries as in India. People don't know, doctor doesn't know. So there are many diseases out there, they are not trained basically. And if you use a systematic way of doing things, then you will come up with something. And then you can have a thought. So it's more like helping the doctor and come up with a wider range and using AI predict that what can be probable cause, what can be symptoms, whether symptoms are still drug or not. So, and which disease it is. Exactly. So in summary, so believe me, I just wrote a summary based on the good questions what Sarah's asked me to do. So just take home message is that finally you have to answer those 5 questions. So Veka is a Java-based tool. Just understand Java-based tool. When you say Java-based tool, it means open source. You don't need Mac or Linux or Windows. You can operate in any OS. Okay. And the beauty of Java-based tool is that you can implement the machine learning without any programming. You don't need to know programming. But you need to have your data sets. I was telling again and again. For using machine learning, you have to have data sets. So once you have a data set, then you can use machine learning using data. Okay. So it's not that you need to do programming or anything else. You can use data. Data is very widely used and it's very popular tool, and anybody can use. And just what you need is a data set.
University of Kolkata to possibly introduce.
Yeah. The only thing you need to understand is the labeling. And based on labeling, and then you give the performance measure. Don't rely on the threshold dependent measures, which are the sensitivity, specificity, and accuracy, but rely on threshold independent measures, which is basically ROC. So you need to focus on ROC, not accuracy, sensitivity. And all AI is not machine learning or deep learning. That you need to understand. I think the take home message is that all AI is not machine learning and deep learning. For example, I just gave an example. There are some knowledge graphs, there are the rule engines, which are AI, but they are not machine. And classification ML models use labels that are binary format. I hope everybody understood, the audience understood. And whereas regression ML models use labels that contain continuous numeric values. For example, I give you an example of C score, which stands for 0 to 25. And the application of AI in predicting the normalities is shown in tools like algorithm rate, which is algorithmic data as an input, and long-term severity predictions, where they use the scores and they use the drug parameters, and the SDLT rate, where the symptoms-based drop the lifestyle-related diseases. Here the lifestyle is written in So this is there, and here what we used, the association between the disease and symptoms and disease and drugs were there, and we tried to compute the direct association between the symptoms and drugs. Thank you.
So I have a question. Can you please go to the cosine similarity, Jacob similarity, and that's yes, no, the next slide. Yes, sir. How it is working? Can you please explain the methods you have used? Cosine similarity.
It's simple. So the thing is that once we have the
so that slide, not this
slide. So when you have this thing, so just compute the vector, this vector and this vector using a cosine value.
Cosine value. Yes.
Because you need a vector, once you have the two vectors, you can make your cosine formula. And similarly for the Pearson coefficient, you can do it, and same the Jacobi rate also. So you need a vector. So the vectors here, for example, suppose symptoms and drugs are there. So what we are doing? We are trying to compute the drug, So for example, so this is one drug.
Okay, that is finding the similarity between the drug and symptom.
Yeah. So this thing is already known, but we are computing this. So based on the similarities, suppose for example, if you take this one and you take this one, because the length is same, 143, 143. And you try to see what is the these and these, and they just use the cosine distance formula and you compute the score and you the same thing, it's a distance matrix. You use the compute the distance and then we do the clustering.
Then clustering is done.
Then after that clustering is done, and then we see how the clustering is performed. And then once we see the better performance, then we see whether the chemical ontology as well as the other part, where the chemical structure synthesis they are within the cluster.
That is only telling the distance value.
Yes. Here we are not computing the distance value, we are computing the exact structures. Suppose in a particular cluster there are 5 drugs. So now we chemical structure similarity of all the 5 drugs. Similarly, the chemical ontology is computed between all the 5 drugs, and then come up with the value, and then it will observe the random factor, which is shown here.
Three databases we used. One is HSDN and CTD. What is another name? One is comparative toxicogenics, and another is human symptom disease network. Another name was there, I think, where the linkage, the association between the disease and drug and symptom and yes.
So one is a human
therapeutic,
therapeutic
yes.
target. So those informations are available. Use data are available.
Sir, is it possible to find out the accuracy of a case of clustering method?
No.
That means I mean to say that
Accuracy
is there any kind of boundaries? How to find the boundaries in case of clustering method?
here. Here.
Yes.
This is the condition which allows you to say whether the cluster is doing good or bad. Accuracy comes only for classification only. So it doesn't come in the non-level part. Non-level part means look at the very beginning of the slide. You are confused between. So this is the unsupervised part. Here you don't do accuracy. Accuracy is only there. You use a supervised research method. And not only supervised method, it has to be classification model. Then only you can get accuracy. Here, regression model, as all are seeing, we go for minimum absolute error or R square. And here, we go for the SC scores. So there are different ways to measure the models. So here comes the accuracy. Accuracy, sensitivity, specificity.
Then sir, how we decide the boundaries in case of clustering?
Boundaries, I think they already formed the what happened basically. So when you use these things in clustering, no? So what will happen in the clusters? The molecules or drug molecules in the cluster, you will clearly see that there is a molecules which are having a similarity based on symptoms and will group together. It's not that a cluster is a map or something, they all group together. So you have to hold this particular thing and see how many of the drugs fall in this particular clusters. So
So I mean to say that the area may be increased, no?
it can increase. If they all have similar score, then have only big cluster. If it's a very big cluster, it's all the drugs fall through. But it's very unlikely. Because you don't have same drug molecule for all the diseases.
Then sir, how we decide that the clustering method is good or not? There is a mathematical tool, no?
So I have to maintain the data and this is the scoring system.
Yes, sir. Okay.
Actually here, we use the scoring system. We use the scoring system, we see number of clusters and we see the cluster size also. The cluster size has to be greater than 2. Because if it's a 2, then we don't have to consider it as cluster. It has to be at least 3. And then this is the scoring system. So these scoring systems gives a confidence that whether the clusters are being good or not. So in this case, we got 480 clusters. And whereas the clusters which are greater than 2, we got only 80. So we work with 80 only. So at least each cluster should have more than 3 or more drugs. At least. Makes sense. But it is equally important, as you mentioned, that it's very important to find out that whether the clusters are doing good or bad.
So what is the threshold value, sir? Then when we consider this error coefficient as good or bad, what is the threshold value?
It's 0.5 and above. If you don't know anything, then you consider default.
On the average.
Default. But it's not ideal, but absolutely. Clustering based method is very complicated. The backend data and many things. So, no questions and confused.
Sir, can you share about the projects going on? I have run through the website. Some projects are going on under your name. In Dinajpur, I think.
share some information so that we can also get interest in this kind of work.
So there are few ongoing projects in my lab. What we're doing basically try to understand the microbes or view of microbes which are present in the lung. Okay. So as you know, there are different microbes play a very important role, like pneumonia, triclinic pneumonia plays a very important role. But what we are more interested in that in case of asthma and COPD, so there are chronic diseases, there are infectious diseases. Asthma and COPD is not it's a chronic disease. But still we found that some microbes play a role. If you know or not, I don't know, but patients who are suffering from asthma and COPD, doctors mainly they give an antibiotic and they give you immunosuppressive drugs. So the question comes here is that why they are giving an antibiotic? And the next question what we have is that many COPD patients they are stable and sometimes they are intensive. So we call it counter exacerbation stage. It means that sometimes happens, certain things popped up and they need to be hospitalized. They need a very special attention. So the question is that our concept is that maybe some microbes or microbiota. Microbiota means the microbes, the metabolites, the DNA or the protein coming from the microbes, they are doing something and they are interacting with the immune cells and having a role, and that's why there is a difference between the COPD stable state and COPD excellent state. So our lab wants to find out that which microbes plays a role and also which microbial metabolites plays a role in interacting with the immune cells so that the immune cells produce a lot of inflammatory cytokines like IL-6 and all those things and they become inflamed and they need some attention. So it's a very difficult problem. So to handle that, what we did was we developed a database which is called most probably called MDB. I think you Google it, you'll find it MDB. So it's a database where we compile all the microbiome of 19 respiratory diseases. So there are 19 respiratory diseases altogether. So whatever the data are available, all the microbiome data, the metagenomics data, we compile all the data. Most probably there are 4,000 studies. So we took all the raw data, metagenomics data, and we try to see. And our database does anything. Suppose you should give any microbes, you will see that whether the microbes profile goes up and down across 19 diseases. So we get a clear picture of what is happening across diseases, and not only a disease, but a disease can be of subtypes. As I was talking about COPD as subtype or COPD stable, so we give each microbes or bacteria, it can be fungi, it can be viruses. You get a overall picture about the 19 diseases as a subtypes. That was one thing what we are doing. And what we believe is that it's not microbe, the microbial metabolite plays a role. Metabolite means the end product, chemical product. So that plays a role. So what we are doing also, we are trying to associate the metabolites with the microbes. It's a very difficult task. Because in the lung, suppose there are so many bacteria there and one metabolite is there, how can we say that this metabolite is coming from a particular microbe? It's very difficult task. But we try to develop methods and we have to stratify it and try to understand that which metabolite is coming from the microbe and which are the metabolite is likely to interact with the host immune cells and produce inflammatory cytokines hormones. This is one project of the doing. Second project what we are doing is that we try to understand what is the role of mitochondria in the obstructive pulmonary diseases. Mitochondria is the power of the cell. And what happens is that in the lung, basically there is a serial movement is there. So what happens basically, whenever there is a mucus formation takes place in the lung, so this cilia they move and they remove the passages within the lining of the lung and remove all the mucus. But what happens basically, whenever the mitochondria is dysfunction. So what happens? The ciliary movement gets impaired. The movement gets impaired. And then what happens? They don't have the power to recruit the mucus. And mucus is a food for all the bacteria present in the lung. Otherwise, lung is a very sterile. Lung is, as I was talking to you about lung is totally different than gut. Lung is more like an antibiotic. Where there is no food available, but still the bacteria can stay there. As you know, many bacteria can stay in that area. But gut is more like an Asian shop where a lot of foods are available. So, if something happens in the gut, there is a operating system is there, and they can cross talk and they can minimize it. But lung is very sensitive. In particular microbe goes up, there's a lot of effect in the metabolite activity and you see a lot of these deficiencies. So small perturbation in the lung can cause a huge effect, but a small perturbation in the gut may or may not really. Continues unless we suffer from video cholera or something or a vector or something like that. So that's the difference between gut and lung. So we study the lung microbiome, that's how we and we try to understand what's the role of mitochondria. So once this mitochondria gets impaired, so as many of you know, the mitochondria has a core complexes and it has a two membrane. So it's a two membrane and it's a core complex. So all the ATP energy is generated from mitochondria. So when the ciliary movement gets damaged or mitochondria doesn't function, this movement stops. Our question is that which mitochondrial complex proteins is getting impaired? Can we detect this? That is another project which we are doing. And the third project, as I was mentioning, that we do some work with Raivan University, and we go to the tribes maybe once in a year, 1 week or 2 weeks. I myself go, and we try to talk with the tribes. The tribes dominate the Dinajpur districts, and we try to study the non-communicable diseases. What are the diseases that are very commonly affected? So, because communicable disease is very difficult, but non-communicable diseases, you can go and talk to them and take the blood, we talk to them, we get a lot of questionnaires around us, we try to ask the questionnaires, and we can use a YouTube as a vector talk, as you know, many of you are understand what is vector is, and we can use what once you have vector, you can do machine learning. So that's what we do, and try to see whether those patients have any the people from the Dinajpur district, the tribal people of the Dinajpur district, whether they have any particular biasness to a particular non-communicable disease or not. Because as you know, the people in the tribes in other districts as well, they take a lot of alcohol which is homemade. So the liver is always get damaged, and there are some other diseases. What we found is interesting, there is a high blood pressure is there. So we are trying to understand if the data, since we are project that we this is one. But at the end of the day, we all doing machine learning, and what we were using is the data.
So you are collecting the blood for what?
Sir, is there any connection with the non-communicable diseases with their genetic makeup?
Yes. That's why we take the blood, because on the blood we can know what are the mutations are there. So that's why we take the blood.
So they allow you to take the blood from them?
Yes, because it's a asthma project, we have genetics, all these things are done. We have the ethical permissions from the locals also. From the ICA1 we got the permission, and also we need to take the permission from the people Anganwadi permission is always it. Permission is another one. How they help for our
Large database, which will much.
Tony was just as
কমিউনিকেশন করে বোঝানোটাও একটা চ্যালেঞ্জ।
হ্যাঁ আমরা কথা বলতে হবে ওরা নিজেরাই কথা বলতে হবে কারণ নিজেরা ওদের ওষুধ দেয় তো ওরা ওষুধ দেয় তো ওদের বলে চলে আসে আর আমরা কি করছি আমাদের টাইপস দেখি প্রবলেম যেটা what we face is that non-type people also come because everything is very cleaned up because we take the blood, we take the report on the next day অনেক লাইফে দেখি একটা আমরা तो ওদেরকে বললাম বুঝে না হয় যে তোমাদের একটু কারেন্টে যাওয়া হয় গাড়ি করে যাওয়া হয় কিছু আছে বাট প্রবলেম এই ডিফিকাল্ট যে 10 জনের মধ্যে 3 জন ড্রাইভ 7 জন নর্মাল অবস্থা থাকে আমরা তো স্যান্ডেল দিয়ে ঘুরে যাই আমরা ট্রেন্ড হয়ে গেছে তো আমি গতবার ওদেরকে চেষ্টা করি ইমাজিনেশন হাউ টু দ্যাট বোর্ড আর ক্যান ইউ পার্ট অফ দ্য গ্রামের মধ্যে কি মাথা হাঁটি হয় পাওয়ার থাকে ওদেরকে ইজি হয় ওরা যাবেই না
তো ওটা তো অনেকটা পলিউশন লেস তো তাতে তো লাংসের এফেক্টটাও তো আলাদা ওই জায়গাগুলো তো কলকাতার রেসপেক্টে অনেকটা পলিউশন লেস
আমরা নন কমিউনিকেবল ডিজিজ দেখি নট লাংস নন কমিউনিকেবল ডিজিজ ইনক্লুড মেনি থিংস জাস্ট লিভার ডিজিজ চোখের রোগ অনেক কিছু হয়
So many lifestyle diseases also.
লাইফস্টাইল ডিজিজ মেনি লাইফস্টাইল diabetes and hypertension. Hypertension is a huge problem. আমরা যদি চেষ্টা করি আর কি hypertension সামনে এটার মধ্যে কিছু হচ্ছে যে কোন জিন ইনভলভ ইন স্পেসিফিক ক্রাইমস
Of their lifestyle.
No, lifestyle also. As I said that they take movement and all.
Actually, gene gets evolved.
That I don't know.
তো বছরের হয়ে জিনের চেঞ্জ
No, inherit করে ওরা।
হ্যাঁ
ওই particular জিনিসগুলোকে আমরা দেখে নিই আর বিশেষ করে দেখার চেষ্টা করি। It's a huge project, but problem.
ডেটা কালেকশনটা কিন্তু বিরাট
হ্যাঁ।
সেলফ এটা একটা বিশাল একটা
তো রাইভেল ইউনিভার্সিটি অ্যাকচুয়ালি করে আর কি আমরা যখন লিভ করা হয় কি বলে যখন ক্যাম্পিং হয় তখন আমি যাই কোনো সময় আমি যাই না তারপরে এটাকে পাঠিয়ে দেয় ওরা একটা আমি দিই আমাকে আমি কখনো দেখতাম না রেজাল্ট আমি দিই
সম্ভব হবে না
সম্ভব এই জন্য হয় কেননা যে মেয়েটা রাইভেল ইউনিভার্সিটিতে কাজ করে মেয়ে আসলে প্রফেসর এসেছে এগুলো আমাদের কোর্স স্টুডেন্ট পিএইচডি স্টুডেন্ট সো কারণ পিএইচডি করতে দেখেছি আর কি পিএইচডি করে ওখানে গেছে তো তার জন্য কম্পিটিশনটা ভালো তো আমাদের স্টুডেন্ট ডিপার্টমেন্ট টিচার আছে
স্যার আমার একটা কোশ্চেন আছে যদি কোনো এরকম পেশেন্ট হয় যার গ্যাস্ট্রোইন্টেস্টিনাল প্রবলেম অ্যাজ ওয়েল অ্যাজ লাং ফাংশনের প্রবলেম রয়েছে তো সেক্ষেত্রে কি কোনো প্রিবায়োটিক বা প্রোবায়োটিক দিয়ে লাংসের ফাংশনকে ইমপ্রুভ করা যেতে পারে?
অবশ্যই করা যেতে পারে বিকজ the concept nowadays is coming up with the heart-lung axis and there's a concept called the heart-lung-brain axis. The heart-lung axis is very well studied. So many times people feel know or not. So people who suffer from lung disease like COPD or not, or many of us we are suffering from the gas. So we just take a connector. That tends to use the metabolites they pass from metabolites as microbes. They pass from the gut to lung. So the gut-lung axis is very well studied. So the prebiotics are generally used for many diseases, many lung diseases, including diabetes and other diseases. So people have found it benefit. The gut-lung axis is there. And another part, as you mentioned about that, and we want to talk at, as you said, one of my students is being the heart-lung-brain axis, which is very important. So what happens, if you observe what or not, many people who are above 60 or 65 who are suffering from COPD mainly or other lung diseases, they also happen to have some ego diseases. So we feel there is a link between the lung and brain axis. Many times, because metabolites they can pass through blood, they can blood in the brain is a blood-brain barrier is there. So, besides blood-brain barrier, there are some molecules which can pass, and they can infect the microglia. Microglia is the macrophage which is sitting in the brain basically, and they have the capacity to make inflammation on the microglia. One microglia become inflamed, they generate a lot of cytokines and then they can damage the brain cells. Makes sense. So the microglia is somehow the metabolites coming from the microbes or host factor, whatever it is, it can pass the darker air and they interact with the microglia, and if the microglia get activated, badly affected, then it can cause hereditary damage because they will release cytokines, bad cytokines or the pro-inflammatory cytokines to be inflame the face cells. So we are also working in this particular area of making that genetics and
Sir, question is COPD की genetic के कोनो involvement আছে?
So most of the lifestyle diseases, there are two factors. One is the genetic factors, one is the environmental factors, and one is the interaction between the genetic and environmental factors. So now it's a question for us how to dissect whether it's a genetic factor only, whether it's an environmental factor only, or whether it's the interaction between the both. So that's a question for us, which is a very difficult question. So most of the lifestyle diseases, these three questions what we always have, we have to address. And lung disease, always have to solve. Because in lung, most of the lung diseases, there are environmental factors that are very important.
স্যার একটা কমন ফ্যাক্টর দেখা যায় যাদের সিওপিডি আছে বা যে বংশানুক্রমিক আছে তারা একটা সার্টেন এজের পরে যে সবাই মানে ফ্যামিলি সবাই একটা ট্রেন্ড থাকে আফটার 55 বা আফটার 60 সবাই ওই একই ধরনের সিওপিডি মানে গভর্নমেন্ট
There are known set of genes already known in the literature where it has been reported already. The usual or genetic factors that last one. Genetic factor is there. That those are very easy to understand. And the problem comes here when there's an interaction between the both of them. So then you need the machine learning and you need more data to understand. But simulation नहीं कर सकते this will be very expensive. ये तो बोले तो it's a simple problem. सवारी बच्चे लोग ये अच्छा genetic factors. और कारों की need also will be very expensive. But it's environmental factors or it's a interaction between the both.
Can environmental factor suppress the gene factor?
Environmental factors suppress gene factors. Generally, when we talk about environmental factors, we take into consideration the allergens. The allergens. Also, we take into consideration the environmental factors like pollution, sound, and they get suppressed.
So they will elevate it.
Because pollution and allergies and they are always elevated. And there are other factors also, but I think some of them have an adverse impact.
Smoking also come under the environment.
Around the problem is COPD is that 70% of the patients suffering from COPD are smokers. But the question lies is where the remaining 30% they are not smokers, but still they have the COPD. How it happens?
In females, biomass full exposure.
Mainly in the cold countries like cold north and places where it is close to DD area like Nepal and all those things. There are reports and papers where because the cold environment outside, you have to close the doors and
Yes, the biomass.
আমার কোশ্চেনটা স্যার মানে যদি এরকম থাকে জিনের কথা আছে কিন্তু আমি কোনো একটা মানে লেস পলিউটেড এলাকার ইনহেবিটেড তাহলে কি সেখানে আমার ওটার চান্সেস কম থাকার চান্স থাকে?
So one project is that the Southampton University UK. So after that, it is a UK that people from the Caucasian population and also the Asian population. So the question is that people are suffering from the pulmonary fibrosis. The question lies here that people who are suffering from pulmonary fibrosis because of UK, whether the Asian population is in UK and the Caucasian population in UK. So the environment is the same. So they can dissect whether the genetic factors play a role. So in this way we are studying. I hope it will be so that is another project which is going on with Southampton University. Because if we talk about the patients of the Indian origin, then the environment is different. Then you can compare it. But if you compare only when the genetic factors are different but the environment is same.
So I hope no more question is there. The number of question actually shows us that how interesting the whole session is. Thank you, sir, for inviting us. Share your any kind of contact so that anybody.
It's very simple. Yeah.
So, I think sir also would like to, sir, would you like to discuss about the journal anything or?
Yes, that's the will start.
So we have to start again.
If you think something to add, because majority have covered that you
So
told.
mainly, I just coming to the card, I was looking at it. Did you go through the paper? Did you go through the paper? No. So while I was coming from Kolkata to here in the morning, I was looking at the figures. And can you open this paper here?
We have not shared this paper with you.
We have shared the paper with you. So the good thing is that some of the figures, without knowing it, I just also shared to you. So in this paper, what they have done is basically they used the PubMed and try to see how AI has been used in the healthcare. So if you look at the figure 1, can you look at the figure 1 please? It's a simple eye chart is actually shown here. And in this pie chart, it showed that across time, you can see a lot of research articles have been published in AI and healthcare. So they choose a term, they use AI and healthcare, and they found that there is an increase in the number of applications in AI and healthcare. That is overall massive increase. It's very simple and straightforward because we know that data are there, and we know that once the data are there, people are using the AI. If you look at a figure 2, can you look at a figure 2? So if you look at a figure 2, I think almost here, figure 2, can you see that whether you can see it? I want to show this slide. as the move from 2040 to the benchmark, the number of people making the research where the AI has been used on healthcare has been increased. So this is very simple. So what is more important here? About this figure. So in my slide also I showed this figure. So AI is a bigger picture, and within AI there is a subset for machine learning, and within machine learning there is a subset for deep learning. So I explained this particular slide. So what I didn't explain was I told you there is a two things, supervised and unsupervised. There is another type of learning is there for the reinforcement learning. So supervised learning, I hope you really understand now. You have the label, and only you can use supervised learning, and you can use classification-based method, and where we have inputs, input, outputs. And if it's unsupervised learning, as I said, whenever there is no labels and not there, then you can go for unsupervised learning. And examples are the clustering-based methods. The reinforcement-based method, I think we talked about that. There is another way, there is AI-based learning. Suppose that the AND colony optimization-based techniques are there. So those techniques are used, and those are called reinforcement learning. So mainly this is how different types of AIs are used. But I think in my presentations, I gave you a bigger picture that what is AI and what is not AI, and what is machine learning, what is deep learning, and what are the examples of machine learning, and what are the examples of deep learning. So can anyone tell me what are the examples of machine learning? What are the examples of machine learning? Show me. Examples of machine learning, SPM, very good. Other two?
Random forest.
Random forest, very good. Show me, and then other two? I talked in a very fast like KNN-based method, and then CNN. And again in my presentation, I showed you one particular machine learning was doing very good. What was that?
Snakeless.
Multi-layer purpose of interest, which is mainly based on DNA. And what are the examples of deep learning? CNN, supervised, you understood what a supervised method, unsupervised method, and reinforcement, as I said, is a based learning, and colony optimization based technique is one of the two, which is used for DMT. So I think in this schematic diagram you understood, and also you understood what are the AIs which are not ML and DA. What are the examples of AI which are not ML and DA?
Knowledge base.
Very good. So you understood now. This is the participation. And this is more like a global health AI market, so they give us some information. And one thing I didn't talk about is that generative AI. So generative AI uses language models, large language models. So this is very popular nowadays, and they use large language models and they use generative AI. Most of the ChatGPT they use GA in this case. And also, if you remember, I was talking about the feed-forward neural network, but the direction was one direction. And there was a recurrent neural network I was talking about. There is a one state unit is there where the output will come again to the state unit and state again go to the your dummy parameters again. So that state unit, what you do is you will change the weights. Okay, so that is what recurrent neural network is. Understood? So what is the difference between feed-forward neural network and recurrent neural network? Recurrent neural network has additional one node. That node is called state unit node. And that output will go to the state unit, and again it will go as a node. And CNN, you call them, but CNN is the part of the existing network. Long short term memory network, myself I don't know. I think they say that it's part of different neural network only. And this transform model. I was talking about the reinforcement based learning, where I was talking about agent-based algorithm like anchor and approximation used for the reinforcement learning. So these are the popular machine learning tools which are used. And the details and applications and the benefits as well as drawbacks have been explained here. So most of the things are self-explanatory because all the things are written here, you can go through this. And also the application is also given a right definition. And the paper I was talking about, one of my paper which was published in 2006, it was based on the recurrent neural network, where it predicts the Bose epitopes. So you know what is epitopes? Epitopes are those are the antigenic sites in an antigen or in a protein where you can predict. So that was I used recurrent neural network. So coming back to there are Bayesian model. I already gave you what is Bayesian model. So Bayesian model is a traditional-based approach, and many of the biologists prefer it because it's very easy to understand. Each feature is given importance because based on frequency, you compute the frequency, and at the end of the day, you multiply all the frequencies, and then multiply all the frequencies having a probability of yes, and also you compute the frequency of the feature with the probability of no. So in this way, you multiply all the features, and then you come up with the values, and then you see these values based on. Based on that, you can predict whether it's yes or no. Yeah, the auto encoder is a very interesting part. For example, the images data. So you have image data. So image data is not a vector. There is actually a matrix basically. So generally what we do, so there are some pre-trained models that are available, like ResNet. ResNet is most commonly used. So what happens basically, suppose you have a histopathological data. Okay. So once you have this histopathological data, we compute this data into tiles. Tiles are more like our tiles which we see in our square tiles, 2 by 2 foot. Similarly, there are tiles, what they use is 5.2 by 5.2. So it's a square basically. So you just put your histopathological data into small tiles, and then you compute many tiles, and then you use the tile as an input to the ResNet. And once you give this matrix and input to the ResNet will use autoencoder and give the vector. Image data you convert into tiles. Tiles is square basically.
Like pixel mask or filter?
No, not pixel, square. Just divide this small square.
Sir, is it mask or filter? Mask.
Mask.
Yeah. For filtering we use mask.
It's not a, so let me explain. So there are several steps I was trying to keep it up, but as you said that, so it's a so what generally we do, for example, histopathological data is there, you convert into tiles. One tiles has a specific size. For example, I12 or I12. Just don't think about the unit. Just we say it's a small unit. So, for example, this particular image have suppose 1000 tiles. So now we have to use a method, and you can understand that at least 70% of the tiles, each tile should have at least have 70% of the data. Because many times what happens in historical data, some part is take the stain and some part doesn't take the stain. So you have to don't use the tiles which doesn't take the stain. So you just use a one vector when you say that at least 100% of the tiles should be colored. So then you remove those tiles. So then what will happen? You will remove at least maybe 30% of the data.
Compression will be reduced.
Compression will be reduced because those tiles doesn't have the full information. So because when you choose the tiles randomly, what will happen? Sometimes you forward 50% 50% of the data is there and 50% is blank, is required. So you don't consider those cases. So if you say you remove the data and then what you do basically, you normalize it next. You normalize the data and then you use the ResNet, which are the PPM model like that. And then once you do, the ResNet is like autoencoder basically. You are giving the matrix and then you do the vector form. Vector form, once you get a vector form, then you can use SBA model in order to get it. So you are converting the matrix to using the autoencoder like ResNet or image data and using it and putting it in a vector. One vector you think you have. Now you can use any traditional machine. So there is a graph neural network. Okay. So in this particular figure 3, it has been shown that there is a prediction from, they are predicting that in 2032 there is a huge, I don't understand the CAGR.
Combined annual growth rate.
Combined annual growth rate will increase by 20%. Prediction is there. So again, the guy was key there. Okay. So this is the prediction. This is not identification. So understand what is the difference between identification and prediction. You are predicting it, you are not identifying it. In figure number 4, the evolution of AI. So as I said in the very beginning, the AI was there. Not that AI came in 2022. AI was there. So 1950s, introduction of the timing test and this history basically how it evolved basically. And the 1997 state where IBM's if you defeated the grandmaster that time, this is the landmark part in the 1997. And again you can see in 2023 the GPT models came into picture and all these GPT models they use at the back end large language models. I think these are all self-explanatory. You can go to the history of how it's evolved. Very important figure, important table where major pharmaceuticals employ here reset the drug discovery, clinical trials, manufacturing landscapes. You can see the most of the companies like Pfizer, Novartis, AstraZeneca, they all use AI and also when they have used I think that's going to. So there, I think they have used partner with. They use AI for small molecular drug discovery, cardiovascular disease, and oncology. And the partnership aims to expedite the new drug candidates and domestic development. So they use AI to predict small molecules. Can be used as a drug against the cardiovascular disease. I think these are all self-explanatory. You can read and another interesting thing. Most of them use the drug discovery. Sanofi also use the drug discovery. Pfizer also the drug development. Novartis also use the drug discovery. The majority of them use the drug discovery or clinical trials. So it's a huge risk. So there are 11 companies. So what does it say? drug industry, they are using AI. Mainly for the drug development. Figure number 5. So we are trying to predict the future integration and application of AI here. So most of the things they divide into two parts. One is short term, mid term, and long term. So precision diagnostics, therapeutics, medicines, how they evolve in short term, long term, mid term, long term. So for taking an example for the precision therapeutics, we know all that CRISPR plays a very important role, and maybe in the precision therapeutics, midterm they talk about synthetic biology or the genomics. So I'll just give you an example of the etope. So there are etope paradox, and people are also trying to predict the antibody. The region of the antibody will bind that antigen, whether they can predict or not. Because there are many diseases that there are nowadays, the monoclonal antibodies that we use, and monoclonal antibodies are very costly. So maybe in the coming 5 to 10 years, people may come up with monoclonal antibodies where it doesn't take much time to produce as monoclonal antibodies. So maybe we can use the artificial intelligence to predict the gap region of the antibody which binds to the antigen. And medical genomics and drug discovery format categories. So they also have flexibility to any questions you want to ask? Because I just go through it and I was coming from over here in the morning. So I was going over the paper. I sort of trying to go through it. But it's a very simple paper. It's nothing complicated. It's a review paper. I think in my presentation I will use more technical terms. This is not being used in that. So any questions I will have to say?
Sir, actually I have questions from different concerns. What I have faced medical আমরা বলেছি if I move with the medical based processing for that particular case it needs a down to travel because আমি একটা মেডিকেল থেকে বেসিক্যালি আমি একটা এক্সাম্পল বলছি বা এক্সাম্পল আমি বলছি যে এই সেলটা ক্যান্সার সাপোজ so data to for that I will yes threshold value but that particular threshold value should be given by some medical practitioners because I cannot judge it or I so from where can I get that particular threshold value?
So I was giving an example of CT scan, which is also an image. Yes. So there are, whenever you use CT scan, there are some radiologists which are expert in understanding CT scan. So they go through it and then they give the scores. So similarly, you have to choose a label, which is a
ধরুন আমি সিটি স্ক্যানে ইমেজগুলো নিয়ে গেলাম গিয়ে বললাম যে আমি ধরুন কারোর কাছে গেলাম গিয়ে বললাম যে
কারোর কাছে না, আপনাকে রেগুলারলি
সেটি সরাসরি পাওয়া যাবে ওনারা সেখানে সার্টিফাই করে দেন because once I get the certification then I can move otherwise no.
Generally we do that way only. And if you go to the ground, if you go to the label that will
Exactly that is
So generally, whenever people, doctor prescribe or ask any question to do for CT scan, for example, so the CT scan will be seen by experts, and they give the
certification.
Yeah, they give the confidence. So there is an issue also now. Issue go to doctor will say something.
And I think so there are certifications that will be used for the
sample and doctor doesn't give any comment on it. That is because doctor will give a comment.
Actually, in order to database to need, যেখানে তো ওনাদের কোনো গ্রাউন্ড ট্রুথ করা আছে
এটাও ইনফরমেশন আছে যে এই কারোর পেশেন্টকে কতদিন এসেছে more important. For example, we have the data with you, tissue paper data with you. Can we predict that how long it will be? Is that what rather than saying it's a cancer? So, taking the doctor for that question here. What purpose we do here? If they are looking at tissue, can we predict whether the patient will survive for 5 years or whether the patient will survive for 10 years? Or the cancer will recur or not. Recur means recurrence committed. So once we give the chemo, we need some more present here. So before chemotherapy, so we get the patient data and you perform chemotherapy. So before chemotherapy, we have the tissue data. Can we take the tissue data and we have the gene expression data as well as the expression data? Sorry, gene expression data as well as the image data. So we use the image data as well as the expression data before chemotherapy and we try to predict whether the patient will recur or not. Recur means our cancer will be cured. Tissue cancer or achieve. That is the most difficult. Or can we predict that the patient will survive more than 5 years after? That is the problem. You have to try the problem. Here you should take the question. Now the human brain is going to so those are the difficult questions to take out. Can we predict the survival rate? Some cases looking at the more prediction of the with our belief. Other parameters of image data, yes, special data, then you develop the model. And what you are saying is that every patient, doctor takes the cancer data, so they always take the data side by side area of the tissue where it's not cancer. So you have the access to both cancer data for the same patient as well as the non-cancer data for the tissue which is close nearby and non-cancer the same patient. Now we develop the model. So what happens is the relative factors in the same tissue. How we develop. So TCGA contains all the symptoms. And the survival becomes more important. That is very important. The thing is that there is a cancer, which believe me, that doctors, they know that the patient won't live. Still they prescribe chemotherapy. Because 30 to 40% people survive with chemo, especially and sometimes you don't need to do anything, especially after they will die. But still they put a huge amount of burden to the family of the patient when giving chemo or something. Can you predict how long? I hope we got the
Thank you, sir. Once more.
Sir, if you kindly share your contacts, it will be helpful for us.
I think it's very easy. Just Saha4 at the rate of Saha4.
Sir, is it mentioned in your presentation?
No.
Fine, then we'll share the link.
For capturing image from the field stain patterns are fine.
মোদক স্যার
Specific matrix.
মোদক স্যার একটু বসুন।
Consider the entire slide area or specific area into a 512 and 512 matrix.
Let's say that we have to consider the whole area.
Whole area.
And then convert it to 512 by 512 squares. Suppose there are 1000 squares. And then
And
consider
for
those squares.
counting the states square, what type of logic processor you have used to identify that?
So generally what we use that at least there should not be non-stained part, 70% of
Stain and non-stain part for non-stain and stain part for identifying which type of processor, logic processor you have used to identify.
So there are only two things which allows you to find out that
Boolean logic processor or
no, it's not a Boolean. So it's a, I think if you want, I can do this.
Sure.
So it's a very simple logic circuit. So you have to use a tool. Take one folder with your 1000 tiles and then use the particular tool and generate another folder with maybe 70% or 80% of the tiles. So removing the 30% which doesn't have those small information. So because you are using a tiles which is 70% are white blank, then you are giving injustice to all the information. That's why you avoid all this.
I would like to request our principal sir, Dr. Bose sir, to deliver this certificate. Sir.
I request Mr. Sudipto Saha to join us.